All right, it looks like we are live. I am Dr. Ellen Hayes from Vios Fertility Institute in the Wisconsin locations, and I am joined today with Rachelle Mallik. She is a dietitian that has expertise in fertility, pregnancy, and postpartum. And today we're going to talk about optimizing nutrition in all of those areas. So feel free to write in questions. We're going to talk through some of this stuff from the get-go, and then we can answer some questions that you guys may have as well. So welcome, Rachelle. Thank you for
Thank
joining
you.
me.
It's great to be
And
here.
do you mind just kind of telling everyone a little bit about yourself and your training?
Sure. So I'm a registered dietitian. I've been in practice for about 10 years, but prior to working as a dietitian, I started my training after getting my nutrition degree at the Weill Cornell Center for Reproductive Medicine. So I've been working in fertility since 2006, which is over 15 years ago now. And I started my private practice specializing in reproductive health. So mostly fertility, pregnancy, postpartum, and breastfeeding, although I do work with some folks who have certain conditions like polycystic ovarian syndrome, but may not be actively trying to conceive. I work with them as well. And I've had this practice for a little bit over 4 years after giving birth to my son, and going through the phases of conceiving and pregnancy and postpartum. And I see we lost Ellen, so hopefully she'll come. There she is. Hi, I'm talking to myself.
I don't know. The StreamYard said an error occurred. It was not your fault. So I'm sorry I popped away for a second.
All good. So I was just saying that my practice, specializing in reproductive health, I've had this practice. It's virtual, so I'm in the Chicago area, but I work with clients all over. And I've been doing this specifically in this private practice for about 4.5 years. And I've been telehealth since I started, which has been great, super convenient for my clients.
Yeah.
I don't have to go to another appointment, especially if they are going through fertility treatments when there's many, many clinic visits involved. So yeah, I work from a weight inclusive, intuitive eating approach. So really focusing on health promoting behaviors, and just, really nourishing the body to prepare for fertility treatments and pregnancy.
That's fantastic. So can you tell me, when you first start seeing a client, what do you do? How do you get to know them and know their habits, and what sorts of exercises and recommendations do you make right away?
Yeah, great question. Well, the benefits of working with a dietitian one-on-one is really the individualized care, that I'm able to do some motivational interviewing, understand where that person is right now, what their lifestyle is like, what their habits are like, because I really want to meet them where they are. You can look at the studies or, the blogs and things that say do X, Y, Z, but putting it into practice, the why and the how is often the biggest challenge people have.
Right.
Although there's definitely always questions about the what, because there's a lot of conflicting information in that space. So I really try to be evidence-based as much as possible, going off the available evidence we have and then helping them put it into practice. But I have them fill out, just kind of standard health intake forms. And then during our session, I really want to understand their health history, their fertility history, their menstrual history, their diet and dieting history, right? If they've ever done intentional weight loss diets or been on restrictive diets, like what motivated those, what were their experiences with those? And then I usually have them do a recall, like what's a typical day in their life of when they're waking up, what they're eating, what they're drinking, when they're moving, what their schedules are like, so that any goals we set are tailored to them. And usually I'll start with more foundational things, like how often they're eating, meal patterns, what they're putting on their plate. And then we kind of fine tune it depending on their needs and where they're starting from.
That's fantastic. I think at Vios Fertility, we really like to focus on the whole patient. We're interested in patient wellness, because I think that really translates into best success rates with fertility treatment.
Yeah.
So I think that nutrition and just lifestyle in general can be very important, and really sort of diagnosis specific sometimes. So it sounds like that's your approach as well.
Yeah, absolutely.
When someone is planning to either see a fertility specialist, or they're even to the point of starting fertility treatment, are there specific diet recommendations that you kind of make across the board? Are there certain things they should be eating, certain things they maybe should be avoiding?
Yeah, good question. Again, always kind of taking an individualized approach, because we have research on certain dietary patterns, like the Mediterranean style diet or the Dutch style, like what the Dutch government guidelines are, has been shown in some cohort research to have a positive association with fertility outcomes. And then there's like the Profertility diet that you may have heard of, and we can go into a little bit later if people are interested. So I might take some things from those research studies and try to help people put that into practice. But of course, if someone has an allergy or an intolerance, or they are vegan for ethical reasons, I really want to meet them where they're at and try to take what we can from the research and put that into practice. And again, kind of what makes them feel best in their bodies. So yeah, there might be definitely foods to avoid comes up. I really try to come from a place of abundance rather than restriction. So like really, what can we add in? And maybe that will kind of move some of those other things out of the way just as a byproduct of adding more in. But some things I would say to try to limit, I'm never black and white, like do not eat this, because we're humans, eat for so many reasons beyond just nutrition. But I would encourage maybe less fast food intake when possible, like cutting back on consumption of soda, diet or regular. And we're in the Midwest, so I should say pop, not soda.
Right.
But yeah, decreasing consumption of pop, diet or regular, because of the artificial sweeteners, but also like the high sugar load in, something that doesn't really have much other nutritional value. Trans fats, trying to decrease those. They are being like removed, or they're supposed to be out of the food system, at least in detectable levels on nutrition labels, I think as of this year, maybe last year. But it can still show up, in certain cakes or a lot of heavily processed packaged foods that use hydrogenated oils. So we might be just mindful of those kind of things in the diet of trying to limit. But other than that, we're really focusing on like what to add in, the, plant-based proteins, the fish and seafood, as long as they're not vegan or have an allergy, whole grains, lots of fruits and vegetables, antioxidant rich foods, monounsaturated fats more often, cutting back maybe on a lot heavily processed red meats, things like that.
Yeah. No, I think that that's great that you take that approach, because I think that just in general, when you're dealing with infertility, it feels like we're restricting so many things and things are getting taken away all the time, that we don't want to make the diet all or nothing, because there's no research to say that it has to be that strict, right?
Yeah, absolutely.
So,
and going into pregnancy too, right? People have so many things that are like, you can't do this, this, and this. It gets even more strict sometimes with certain food things in pregnancy. So really coming from that place of abundance in the fertility space, as well as moving into pregnancy, can be really empowering.
Yeah. Well, so during the pandemic, I feel like a lot of people's health has slid a little bit as far as nutrition and exercise and all of the things. So I have a lot of patients that I'm seeing recently that feel like they either want to lose weight, or maybe they need to lose a little weight in order to be able to do certain types of treatment. So they've resorted to a keto diet. So what are your thoughts about that? Because personally, once they're starting treatment, that's not my favorite type of diet for them to be, following, or certainly during pregnancy. Am I right about that? What do you think?
Yeah, it's not something I recommend often. Like, again, I'm always going to meet someone where they're at. And if they're following it for some reason, I want to understand why and where they're coming from. I do have some studies on the potential negative aspects of keto in the periconception period, right? The time before and before conception, which is when, we're talking fertility treatments as related to gestational diabetes, increasing risk of gestational diabetes, and of neural tube defects, which is pretty concerning. And it was from a 2021 review study. Can I share that? Would that be okay?
Yes, absolutely.
So low carbohydrate diet. So I was trying to dig into the diet, the study, right, that this was review study was looking at, to what they meant by low carbohydrate. The overall review study was talking about keto, but it said low carbohydrate, and keto is extremely low carbohydrate. It's usually less than 5% of calories. So low carbohydrate could be, 30% of calories or even 40% of calories. So just keep that in mind, right? That keto is even more restrictive with regards to carbohydrates. So low carbohydrates diets followed prior to conception or during the periconceptual period are associated with an increased risk of birth defects and gestational diabetes, respectively. Interestingly, a stronger association was seen for women following a low carbohydrate diet pattern high in animal products. They had a 36% higher risk of gestational diabetes, And a vegetable-based low carbohydrate diet pattern was not associated with this increased risk of GDM, so gestational diabetes. So I think it's also important to consider what you're putting into a low carbohydrate and or keto diet. There's a lot of benefits to eating more fruits and vegetables and, you know, plant-based proteins and such for the fiber and the role in gut health and inflammation. And, you know, bowel movements and all those things that are really important versus like just eating a bacon wrapped cheeseburger with no bun. You know, there's a big nutritional disparity between those things.
Yeah, I think that unfortunately that's what a lot of people think of when they think of a keto diet, is a lot of meat and butter and, you know, definitely a lot of animal products. So do you think that the increase in birth defects was perhaps due to nutrient deficiencies because there were too many of those foods and not enough produce? And
so the birth defect one was related to, they just said in the prior to conception period versus the periconceptual. And yeah, they believe that there's some correlation with folate. And this was prior to folic acid supplementation in the food system. So they think it has to do with something like beyond that, that it's not just the folate itself, but there may be some role there. Obviously, we know that folic acid or folate is really important in preventing neural tube defect. And of course, like that can be a really scary stat. So I don't want to say like no one should ever do this, but again, if I always want to come back to why they're doing it and how is that diet supporting them if it is, and how can we make sure that they're doing it in the most nutritious way? It's definitely not something I recommend, but again, I always want to meet people where they are and understand why they're doing it, because I've also had experiences where like the person didn't work with me for fertility or preconception, but then they're pregnant. And what happens in the first trimester? And you're super nauseous and all you want is carbs. You know, so there's this fear, right? Well, I got pregnant because I was avoiding carbs. Now, am I going to hurt my pregnancy? And I've heard this, like people saying that, and that's really concerning, that they're worried that having a bowl of cereal is going to result in, you know, negative pregnancy outcome. So we consider as the mental aspect of all of this.
Well, I think there's a huge mental aspect because there's so much different information just coming at us now. You know, in the news and social media, and a lot of it is not based on science, you know, so people are getting a lot of mixed messages and it's stressful, I think. So if you had to boil it down, I mean, the way I approach it with my patients is, you know, if you can make some nutrition changes now that are healthy for fertility, they should be healthy for pregnancy and probably healthy for the remainder of your life, and just kind of keeping you at lower disease risk in general. Those types of things are going to be good for fertility, right?
Right. Yeah. As we were briefly chatting about before, you know, there are definitely limitations with nutrition research studies in general. Most of the time it's going to be this correlation, not a causation, because you're not going to put people in a bubble for 30 years and see what happens, right? They're still living life and eating in certain ways and exercising and moving and stress and all these other factors that we can't necessarily control for. But most of the research that's been positively associated with improved fertility outcomes, whether clinical pregnancy, you know, live birth, which is really the end goal, are things that are generally supportive of long-term health, of reducing cardiovascular disease risk, of reducing diabetes risk. So yeah, really setting the good foundation for your health and potentially even modeling that behavior for, you know, future children of how to, you know, treat your body with respect and nourish it with good food, you know, and not come from a place of like punishment or restriction.
Yeah. So when patients come to see you and they aren't at what would be considered a healthy BMI, I know that you don't like to focus on that entirely, but, you know, how do you approach that subject with your clients?
Yeah, the BMI is an interesting one, because I don't know how familiar you are with like how it was developed in the first place and just the limitations, right? All it's telling you is height over weight. That's it. That's really not a good measure of anybody's health. You know, weight and health are not synonymous. So people can have weight concerns, but weight isn't necessarily as one for one, like calories in, calories out, and you should lose weight if you do X and you should gain weight if you do Y. So I always come back to the behaviors, right? What are those health promoting behaviors? And sometimes the research of like weight showing to improve X doesn't tease out was it because they started eating more fruits and vegetables? Was it because they were moving their body more? Was it because they were eating more fiber, drinking more water, cutting back on heavily processed foods versus like the weight itself? Was it the behavior? Was it the weight? And because weight is not this linear thing, and it can set people up for maybe feeling like they failed, right? Because their weight isn't correlating with those behaviors, right? That they're doing all the things and their weight's not going down in a way that they are told it should, then that can be really disheartening versus like using the outcomes or the measurable things as like, okay, how are you doing with your fruit and vegetable intake? How are you doing with your whole grains? How are you doing with your fish and seafood intake? How often are you moving? Like using goals that are not weight specific, because then those feel more achievable and you know, again, that they're really supporting their health, whereas the weight may or may not change in accordance with that.
Yeah. I think you make a good point that, you know, BMI doesn't tell the whole story. Obviously, we need some measure of height and weight to do fertility studies with. And so BMI is one that's frequently used. And we know that if you're either overweight or underweight, you won't necessarily have best fertility, but normal BMI, it will give you your best fertility. But there are a lot of things that play into that. Nutrition studies are hard to do because they take a long time. So yeah, I mean, I think that patients worry at higher BMI that we won't let them do treatment because we think it will impact their success rate, and that reflects poorly on us. Actually, the reason why sometimes people will have a BMI threshold for certain procedures is just to keep them safe when we're doing IV sedation in an outpatient setting, and just to make sure during the IVF process that we aren't putting them in harm's way. So BMI has to come up, but I also think you're definitely right. It's not the whole story. So it's always this kind of give and take and conversation about getting people as healthy as possible, not only for best outcome, but so they can proceed with the treatment that they would like to do as soon as possible, because obviously time is of the essence and everyone wants to be pregnant yesterday, of course.
Right. Well, can I ask a question too, when that does come up? You know, if I don't know what your experience is or what you're talking to your patients about, but when patients are just told kind of point blank, okay, you need to lose weight or your BMI is too high, but they're not digging into that patient's health and their history, how do you know that they don't have an eating disorder? How do you know that they haven't had a history of long-term dieting? So many of my clients who are in these, you know, BMI categories that might be like higher than what's considered normal, you know, do have a lot of weight and dieting history because of the stigma around weight. And so, you know, that the weight stigma has been shown to be harmful to health. And then, you know, they're like the kind of traditional weight loss approaches won't work because they've kind of messed up the metabolism through a history of yo-yo dieting, not to their fault, but because of what they've been told they need to do to support their health. So, yeah. And, you know, to your point, outpatient is different than a hospital-based procedure where there's going to be, you know, different kind of anesthesia and access to, you know, safe ways of intubation or something if needed.
Right. So first and foremost, we want people to be safe during their fertility treatment, but we also don't want to just kind of exclude them and make it impossible for them to proceed. So it's definitely something that we like to collaborate on. And it can
dietitians are here.
Yeah, exactly. I mean, and you're right. I think a lot of these patients, and that's why when it comes up, I do talk to them about, you know, have you ever lost significant weight in the past? How did you do that? You know, just kind of trying to dig into it a little bit more and see if there are solutions. But I think a dietitian is a huge help in that area, not because you're going to maximize weight loss in an unhealthy way really quickly, but because you're going to do it the right way. I think the bottom line is we want to do it the right way.
Right.
Why don't we take a couple questions? So here's a very specific one. So what are some foods to avoid if you are experiencing bloating in early pregnancy and or from fertility medications? Because I think people do get some GI upset, you know, definitely in pregnancy. And so our patients, obviously, that have success with their fertility treatment, we follow them during their first trimester and they have nausea. They sometimes have other GI complaints, but certainly fertility medicines and quickly changing hormone levels can cause some GI problems too. So what do you advise?
Yeah, it's a great question. I mean, with the fertility treatment, right, you're growing, the ovaries are growing so much that people do experience this distension and
Right.
sensation of bloating. And then, of course, once progesterone is added into the equation, that slows down the GI tract, so that can make people more constipated. And if you're constipated, any gas production as a byproduct of digestion of like various foods is going to exacerbate that, right? If that gas has nowhere to escape to, it's kind of hitting a roadblock. That's going to make it even feel worse. So I'd say, without knowing this person individually and kind of tailoring it to them, it's like making sure you're kind of having a good bowel regimen to promote having regular bowel movements. That might include, adequate fiber, adequate water, using a squatty potty to help with just like the actual alignment for a bowel movement. And then, you could certainly cut back on any foods that you notice seem to exacerbate your symptoms. Like, I love beans and lentils. They're a great plant-based food, but for me, it was someone who has some GI issues, like beans and lentils can be particularly triggering for the, worsening of the bloating and gas. So you may want to cut back, or at least, they're a great source of protein. So maybe rinse them really well, or use canned versions that are a little bit lower in some of the gas. And yeah, just making sure that you are including a good variety of fiber-rich foods to help kind of move things through. But not too much fiber, right? Not like loading your body
right,
to exacerbate the bloating. So it's kind of like, titrating up, if you will, and how much fiber you're getting in, and movement too, right? Like just doing some, whatever is of course allowed if you're in the fertility treatments, whether it's some walking or some light yoga that doesn't involve too much, strenuous activity or twisting, but that can help too.
Agreed. I think, a lot of women get nervous during their fertility treatment, especially during IVF, and they think that they have to stop exercise completely, which obviously is not necessarily the case unless there's a good reason. And same with early pregnancy. There may be reasons why we say, okay, limit activity in some scenarios, but usually you're able to maintain some of those, light to moderate activities.
Yep.
And that can be really helpful, just, overall well-being and how you're feeling and how you're digesting, right?
Yeah.
Okay, so another question, what are the best go-to snacks? So I'm sure there's a wide variety, but are there some things that, if someone planning fertility treatment just wants to start slowly introducing some healthy changes and maybe swapping out some unhealthy snacks with some good ones, are there things that you recommend routinely?
Yeah, absolutely. I definitely have some go-to personally, and then with clients, we'll talk about. Generally, I try to get people to have some protein and some produce, like fruits or vegetables. And when produce is not an option, something with fiber, right? So that you're getting sustained energy, getting a variety of nutrients in that snack. So it's not just like a bag of pretzels. Nothing against pretzels, especially first trimester. Like,
yeah, exactly, lifesaver.
Yeah, but the idea that like something that's going to give a little bit more nourishment, a little bit more long-lasting energy. So, like apple and peanut butter, or banana and almond butter, or cheese and some carrots, or crackers and hummus, a whole grain cracker, or like a seed-based cracker, something that has a little bit more of that protein and fiber. So yeah, I kind of always come back to like, okay, a little bit of protein, a little bit of either that produce or fiber-rich food. So I have a good pairing. Lately, I've been really into carrot and peanut butter, just as something that because like
I saw it on your Instagram.
That's something like I get these kind of wins for like a couple weeks. I'm like into a particular one.
It looks so good. I wanted to have it too. I didn't have any peanut butter, and I saw your photo of it, and actually that looked delicious.
Like a good sweet, crunchy carrot. Yeah. And then popcorn and a handful of almonds. Something where again you're getting some fiber, you're getting some produce. Dark chocolate covered strawberries, right? If you're wanting something like post dinner, because you're getting some magnesium and fiber and antioxidants in the dark chocolate, and then you get the fruit and the fiber and all those good stuff from the strawberry or whatever fruit you like.
Yeah.
Too.
Yeah. So I feel like maybe swapping snacks for something better is a nice, easy way to start introducing change.
Right. That's a great way to get some antioxidants in,
Yeah. Yeah, absolutely. Okay. Oh, here's a good question. I'm super interested to hear your opinion. So intermittent fasting, is it good for insulin resistance and inflammation?
Yeah, so intermittent fasting is not something I recommend for someone trying to conceive, and certainly not during pregnancy, because we really want to provide adequate nourishment. We want the body to feel safe to reproduce, right? Not that it's in this like, deprivation state, or like where food access is limited. So it's not something I typically recommend. If we're talking about insulin resistance, I typically recommend like having regular meal times and snacks, so you're having consistent carbohydrate intake, have carbohydrates with your breakfast, lunch, dinner, and a snack, trying to choose the more fiber-rich options because they're going to be a lower, GI, lower glycemic index. So yeah, with intermittent fasting, definitely not something I recommend for fertility, just because, again, we really want to be focusing on nourishment. And if you're cutting out a whole meal or like up to 6 hours of your day, it's going to be hard to make up those nutrient needs just by like bookending it in the afternoon and evening.
Yeah. Well, so when people ask me about that, first of all, I ask them, what do you think that means? Because there's so much confusion out there with even what the definition of intermittent fasting is, right? Because some people will take it to mean that they don't really eat much at all on 2 or 3 days a week and eat whatever they want the rest of the week, or the time restriction, right? Which is what I think you were talking about, where they might have a really tight window of time where they have all their calories and then all of these hours of the day when they're having nothing. I usually recommend against that too. If they're really married to doing that, I say, you need to have a little more generous window of time that you're eating then, right? So I don't know if there's any magic number, but I usually say you don't have a tighter fasting window than maybe like 12 hours, right?
That's pretty much what I would say too. Like, doing an overnight fast where like, 7, 8, 9 o'clock at night, you're, kind of ending your intake, and then 7, 8, 9 in the morning, it might be when you start breakfast, keeping flexibility in mind, right? Because one of the other challenges I see for people who have tried that is that they may not even be hungry, but they're like, I have to get my calories in because this is my only chance to do it. Or they might just like, because there's restriction on other days, just like eat whatever they want. But it's not even what they want. It's just because that's the time they can have it. So it's less like autonomous. It's a lot of like externally driven rules versus like internal, like how hungry am I? What am I in the mood for right now? So yeah, I think there is definitely a difference between complete fasting for say 2 days and eating for 5, or doing like 18-6 or something, blanking on it. Like I think it's a 6-hour eating window and 18 hours. Like, I just think it's not really supportive at this phase of your life. But that, maybe doing an overnight fast, keeping in mind, again, flexibility for that. There might be that time that if you're hungry, you should be eating, right? Or
especially in pregnancy, I would say, especially in pregnancy, there's no reason to stick to a time frame if your body is telling you otherwise.
Right. Your body telling you it's hungry is usually a sign to eat. And if you're struggling with mindless eating, then that's stuff we can work on, like tuning into those cues and your satisfaction and all that kind of stuff.
Yeah, absolutely. And I find that a lot of patients, if they try to stop consuming calories, maybe 2 or 3 hours before bedtime, they feel like they sleep better too. So, parameters like that, I think, make more sense than, necessarily the same window of time every single day.
Right. Yeah, absolutely. More of like the timing than the number itself.
Yeah, exactly. Okay, we have another question. If trying to reduce inflammation, do you need to eliminate 100% for the effect on inflammation? Oh, meaning like if you have a food intolerance, or is it okay to have those foods in smaller portions but still have the good effects on inflammation? So they're asking in the context of endometriosis, PCOS, IBS, all kind of inflammatory conditions.
Yeah. So it's a really great question. This actually came up in session with someone last week about, nothing exists in this like black or white way in our bodies, and things that affect nutrition are generally the patterns over a longer period of time, right? So if you're generally following an anti-inflammatory diet, when you're focusing on more, plant-based proteins and fruits and vegetables and olive oil and, whole grains and such, then having, say, a piece of cake is not going to like derail all the anti-inflammation, right? It's not going to cause this like huge surge in inflammation. And also like lactose intolerance doesn't require removal of dairy. It requires a limitation on lactose, which is 2 different things versus like a milk protein allergy or vegan. So I deal with IBS, so I'm cognizant of my lactose intake, but I don't avoid dairy just because personally I enjoy it in my diet. And it hasn't been shown to be inflammatory in various research studies. But again, there always has to be context considered with everybody's situation, the rest of their diet, their medical conditions and such. But kind of the straightforward answer is like, no, you don't need to eat 100% of like only inflammatory foods, because that takes away some of the pleasure and the satisfaction from our diet, and that can get really hard to do forever, right? Like, how long are you trying to do this for?
Agreed. I think some common sense comes into play, right? If there are certain things you eat where you feel absolutely miserable, then sure, you know, if you're pursuing fertility treatment or you're pregnant, maybe try to avoid those most of the time. So I feel like it's mostly common sense. And so the food allergy tests, I'm sure I've heard that those are not reliable. I don't know if a lot of my patients are doing it. I haven't heard that many of them are, but is that a reasonable way for anyone to check for food intolerance, or is that really just more of a marketing gimmick?
I mean, as somebody who deals with food intolerances, I wish that they were better. They're not validated, meaning that you could do the same test and have different results the second time that you do it or the third time. A lot of times they'll, because of things that float around in our blood, will show up foods that you eat often, right? And it's like, oh, I need to avoid this. It's like, it's just showing up on this panel because you eat it and it's showing up in your bloodstream. So they're not usually that reliable. Food allergies are different than food intolerances or sensitivities. So again, somebody yesterday had taken with going through fertility, had taken a food sensitivity thing. And we, you know, were like, okay, what did that show? How does that apply to you in your life? And, you know, we could certainly work on some elimination. Like, I always consider their history, right? If they have like an eating disorder history, then we usually don't do eliminations. But if they're like noticing some really significant symptoms, then we'll trial removing it and seeing how they feel, and then adding it back in and seeing what amount they can tolerate if they're interested in adding it back in. Yeah.
So based more clinically than on any particular test that you can do.
Right.
Makes sense. All right. Next question. Caffeine and fertility treatments, question mark?
What you talk to clients about, you know, then we can talk about some of the research there.
You know, I usually recommend that they try to limit to about 150 milligrams a day of caffeine. So the equivalent of maybe 2 8-ounce cups of coffee. I like to know what form they're getting their caffeine in. You know, is it coffee with a bunch of sugar and whipped cream on top? Is it Mountain Dew? You know, sodas, things that are just completely easy to eliminate and great to eliminate. But I don't tell them that they need to eliminate caffeine completely. A lot of patients come to see me already having done that because they think that they have to, but I do not believe that they do.
Right. Yeah. I mean, the research shows that it's not necessarily harmful to fertility, you know, in the period leading up to fertility treatments or even during. You know, did you see that recent like committee paper from ASRM on like lifestyle factors? I know that was discussed that too. So I always take it back to the individual, and I'm similar. You know, I try to say like, let's go under 200 milligrams, which like ACOG sets as the, you know, considered what's safe in pregnancy. Because I've also seen some research, at least in pregnancy, that shows there may be some negative outcomes with like even less than that 200 milligrams. So I try to get people to just cut back to the point where they can still, they don't resent me, you know,
right.
Away all the fun. You know, maybe we do a half-calf drink, maybe we do a decaf, maybe it's just that warm beverage that they enjoy, and the flavor. Like I love coffee, but I do a lot of decaf because IBS, you know, not exacerbate that. So, but if someone's, you know, at 3 cups and they go down to 1, that's huge. Or if they go from 5 to 3, like that's still some improvement. So again, always meeting people where they are. And I'd say I probably more though, like that 200, 150, 200.
Yeah, absolutely. I think we're on the same page with that. Here's another question. What should I focus on when I'm so nauseous? I don't know if they mean during fertility treatment, because that can be the case when you have high estrogen levels, or in the first trimester of pregnancy. Do you have any tricks of the trade for nausea, you know, food-wise?
Yeah, so this rarely comes up with my fertility clients. They get more of the bloating and, you know, distension and such. But like nausea first trimester, usually it's a good sign as much as it's
exactly. It's reassuring.
But yeah, there's not good really evidence-based. It's a lot of kind of anecdotal stuff, even in the literature of like how to navigate it. But B6 has been studied, like supplemental B6, as helping reduce nausea but not vomiting. So I think the dosing is 10 to 25 milligrams, like 3 to 4 times a day. So we might try that out. Ginger, like teas, or, you know, there's even lozenges, like brands that make a ginger NB6, you know, lozenge they can try. And then and food specifically, a lot of times people will notice that they feel more nauseous if they're really hungry and they're really full, right? So like the nausea can be exacerbated by extreme hunger or fullness. So really trying to like eat probably every 2 to 3 hours, like small meals, and trying to pair some protein with it. That's been shown, at least in one study, which is the only one we have, that protein with carbohydrates has been shown to reduce some of the nausea. So it's like, okay, I can only tolerate crackers. Can you put a little peanut butter on their cracker? Could you put some cheese with that cracker? Like, it doesn't have to be a honking piece of, salmon, but like,
right.
I don't know, honking's a description of a size, but a hulking piece of salmon. So, just trying to get a little bit of protein in there that may help with some of the nausea. And then avoiding really like odorous foods. If you can get somebody else to cook for you, maybe you do cold food that doesn't give off as much aroma. So there's a lot of things that we can try out. And most of my clients are interested in doing those things before turning to a medication if necessary.
Yeah. I mean, there is a point that they may reach where they need medication, but I think a lot of those things are incredibly helpful and keep a lot of people from requiring medication in the first trimester.
Yeah.
Is there an ideal macronutrient range to optimize fertility?
No, there is not an ideal.
Good, because I wasn't aware that there was. So
yeah. Again, this is a kind of like what's called the AMDR, it's like the macronutrient distribution range. I'm forgetting what the A stands for. But it's basically what the guidelines are, is like what's considered kind of good for overall health. And carbohydrates are usually like 45 to 60% of your intake, fat being 20 to 35%, and the remainder being protein. So that's like 25%, 20 to 25%. So like you can see those are ranges, right? So you might be at the higher end. Like if you're vegan, you might be at the higher range of carbohydrates, just because even your proteins are going to be a little bit higher in carb. Whereas you might prefer to have a little bit less carb and more, protein or more fat. So there's ranges, but there's not like an ideal for fertility. Although in the PCOS space, like some research points to some like carbohydrates being like 40 to 45% of the caloric intake, just to help navigate the insulin resistance. But again, always want to take that on an individual basis and not just be like, cut back on your carbs, right? Because like, what if they already have done that, right? Or what if they're just like, there's so many other things that may be going on in that person's life that just telling them to cut back on carbs may not be helpful, even if they do have PCOS.
Yeah. And a lot of these things, there are many lifestyle factors that can lead to improvement. Nutrition, just one of them. So they don't necessarily have to be as militant about that.
Right.
Okay. Another question. Should those who are already pregnant change their diet for pregnancy and postpartum? So maybe they were eating a certain way, became pregnant, and for pregnancy and postpartum, is there anything specific that you recommend that would be different?
Well, I think it depends where they're starting at, right? Like we were talking about before, if someone was doing keto, then once they're pregnant, that may not be the best approach. They may be able to stay on like a lower carbohydrate, like the lower end of that, AMDR, because there are increased carbohydrate needs in pregnancy. But that it's really, in terms of any changes, one, I want to support fertility in a way that's sustainable and can be generally carried through pregnancy, keeping in mind that first trimester, there's usually a bit of a change, right? And that's why there's benefit to making some changes pre-conception and building up some nutrient stores, because that first trimester can be really difficult. You're like, all these great foods that I was eating, I have no interest in. Like, I've been there and I get it.
Yeah.
So I think, taking some pressure off there, that you don't have to have this perfect diet for pregnancy. There is no such thing for that, or fertility. But, with pregnancy, you do deal with a bit more food safety concerns, right? Of things that, because of this slight immune suppression, that you might want to be mindful of your raw, avoiding raw or undercooked meats and fish and eggs, or, being mindful of how much mercury you're getting from fish, although I'd say that for fertility and postpartum too. And caffeine intake. So there's not massive changes, but I think food safety is kind of the big one that comes up as a major change. But really the things that are supportive of fertility will be supportive of pregnancy and breastfeeding. And it really comes back to nourishment and fueling the body for all these phases of life that come with unique challenges. Like putting nutrition into practice is different for fertility than it is for pregnancy, than it is for postpartum.
Yeah. And that's why meeting with someone like you is so incredibly helpful. You mentioned earlier on the Profertility diet.
Mm.
Can you sum that up maybe briefly?
Sure. So this came out of the Earth study. So it's this ongoing prospective cohort, meaning that they're looking at these people going through IVF going forward, not just looking back at them, right? You understand what a prospective, but I know some of our watchers may not. Cohort, meaning a group of people going through this experience of ART, of IVF. And what they found was that the higher adherence to a pro-fertility diet, which based on previous studies, the Earth study researchers kind of narrowed it down to higher intake of whole grains, soy food, dairy, seafood in place of regular meat, and then supplemental like B12, folic acid, and vitamin D were associated with higher rates of implantation, clinical pregnancy, and live birth. So it's not to say that like every single person who's trying to go fertility should follow this pro-fertility diet, but what's really interesting is it was based on previous studies. So it's kind of like adding on to it. And they also compared it to other supportive diets like Mediterranean or the healthy eating index, right? And they found that this had the best outcomes, what they defined as this. I think that's all the foods that are in it. I have it right here. Did I address them all? Yep. And low pesticide produce was the other.
Mm-hmm.
So it's slightly different from the Mediterranean diet. And what they think is the researchers think it's because in Europe, certain pesticides are banned that are allowed in the US. So that, people in the US undergoing fertility treatments may be exposed to more pesticides. So it's not to say like only eat organic or not to eat produce, because that's definitely not what we want. But, really to try to, I do encourage people to try to choose organic for some of those higher pesticide residue produce when it's accessible and available. I think that's a really important caveat.
Right.
I would rather you eat a strawberry than not, just because it's not organic, but like if you're kind of titrating up and maybe this is something that's available and accessible to you, that like, okay, for berries or for spinach, try to choose the organic. But if it's a banana or an avocado, something you're taking this thick peel off of, it doesn't seem to matter as much. But yeah, those are some of the takeaways. And I think, what I also see from that is like people try to avoid, grains or gluten, and that's been shown in various studies, whole grains to be positive, or soy being harmful. And that's been shown in several studies to have a positive effect, or dairy has been shown in several studies now, to be either neutral or positive. So it's, again, not this one size fits all approach, but that like, if you've been told to avoid something, does that work for you? Does that make sense for you, and why?
Yeah. Yeah. I love that you brought up soy, because a lot of people think that soy, needs to be avoided at all costs, but it actually is healthy for fertility and lifelong. So
yeah, there's been great research on, and even being protective against BPA, like the, endocrine disruptor in fertility. People.
Oh my gosh, there's so many things to talk about.
That's a whole other conversation.
Yeah, the toxin talk, all of those things, of pesticides. There's a lot really that we could talk about. Maybe we'll have to reconvene at some point and have some other subjects that we cover. If someone wants to meet with you, because you're virtual, they could really be just about anywhere, right?
Basically, yeah.
How would they go about, scheduling a consultation with you?
Yeah, so most people just visit my website, Rachelle Mallik. That's it's in the screen here, RACHELLEMALLIK. Double L's in both names, that can throw people off. So they can go to my website. They can schedule an intro call with me. I offer complimentary intro calls just to make sure we're a good fit for working together. But some people will just like book an initial consultation as well via email or again, messaging me through my website. And usually we'll schedule the initial consultation. I have them fill out forms ahead of time, really kind of meet them where they're at, learn about who they are and what stage of their journey they're on, and start setting goals in our first session. And then we schedule follow-ups as needed, based on their needs. And there's not like everyone has to meet with me for this period of time, but I'd say most people, 4 to 6 months is a good period to make sure that the changes are able to become more habits, more habitual than, something on their to-do list.
Yeah, absolutely. And I know we send patients your way, and they've been very happy with you and with the advice you've given. So thank you very much for the work that you do.
My pleasure.
So again, I'm Dr. Ellen Hayes. I'm one of the reproductive endocrinologists and infertility specialists at Vios Fertility. So if you are interested in scheduling with Rachel, she explained how, if you're interested in scheduling a fertility consultation with one of the Vios physicians, We have many locations at this point. Myself, I'm in Milwaukee, Wisconsin, but we have Chicago, we have St. Louis, we have Vancouver, Washington, we have Detroit, and many more to come, I am sure. Please visit viosfertility.com to schedule a consultation, and we'd be happy to meet with you. Thanks for joining us today, and thank you, Rachel.
Thank you. Take care.